Hello everyone, my name is Jose, and today we are going to talk about the pathophysiology of Hashimoto's thyroiditis and the pharmacology of levothyroxine. So just a quick overview. The objectives of this presentation is to understand the pathophysiology of Hashimoto's thyroiditis, or HD, understand the pharmacological intervention for Hashimoto's thyroiditis, and consider the nursing practices for levothyroxine administration. So the first stage for the pathophysiology of Hashimoto's thyroiditis is the autoimmune response. So it is the development of antibodies to a variety of thyroid antigens due to genetic and environmental triggers such as infections, stress, or exposure to chemicals. The most common is antithyroid peroxidase, and many also form thyroid stimulating hormones, or TSH, receptor blocking antibodies. Then these antibodies attack the thyroid tissue that would eventually lead to inadequate production of thyroid hormone. And after that, we're gonna have the lymphocytic infiltration and the production of antibodies. Now, because of the autoimmune attack, immune cells that include lymphocytes infiltrate the thyroid gland. This action is composed of T cells and B cells and other immune cells that form follicles and germinal centers within the thyroid. The immune system then produces autoantibodies against thyroid-specific antigens. The most common found in HD are antithyroid peroxidase antibodies and antithyroglobulin antibodies. These antibodies will target and damage the thyroid cells. And after that, we're going to have the thyrocyte destruction that would eventually lead to inflammation and fibrosis. The frequent immune attack will lead to the destruction of thyroid follicular cells responsible for producing thyroid hormones, or thyroxine, and thyroidotrypsin. As these cells are damaged, the thyroid's ability to synthesize and secrete hormones diminishes. That's because of this, the development of hypothyroidism will take place. Now, as the thyroid cells are destroyed and the thyroid gland is not functioning as it is, the production of the thyroid hormones eventually decreases. This will lead to hypothyroidism, or low levels of thyroid hormones in the bloodstream, which then causes symptoms such as fatigue, weight gain, cold intolerance, and the progression of the disease. The progression of the disease, however, varies on the patients. It could be slow or may not experience symptoms at all. Some will have a progressive decline. Common early presentation of hypothyroidism is fatigue, constipation, menstrual changes for women, brain fog, and goiter, or the inflammation of the thyroid gland. Now, the most common pharmacological management for Hashimoto's thyroiditis hypothyroidism is levothyroxine sodium, or levothyroxine Sandoz here in Australia. You can look it up on the memes. It is under the class of endocrine and metabolic disorders. Now, levothyroxine is a synthetic version of the natural thyroid hormone thyroxine. Usually, the hypothalamus secretes thyrotropin releasing hormone, which then stimulates the anterior pituitary to release thyroid stimulating hormone, which then stimulates the thyroid to release thyroxine and L-thioethionine of thyroxine, then gets converted to its active metabolite L-thioethionine, and this mechanism in the thyroid is not possible due to the disease. So here comes our levothyroxine. Levothyroxine is orally administered and is absorbed from the jejunum and upper ileum. Then it will bind to plasma proteins, and then it will be degraded by the liver, which then convert it to a diethylthiothionine. Then the thyroid hormones then work by binding to thyroid receptor proteins contained within the cell nucleus. Then it's gonna act as a synthetic hormone. So what are the nursing consideration in Rebecca with levothyroxine intake? First is we need to monitor dosage adjustments. Regular monitoring of thyroid function is important during the initial period of treatment to determine the exact dosage that needs to be administered. The goal is to bring down the TSH levels to a normal range, as she has elevated TSH due to hypothyroidism. And also we need to arrange follow-up appointments for TSH level monitoring and assess for signs of overdosage. For the administration consideration, if Rebecca is going to take levothyroxine, levothyroxine needs to be taken on an empty stomach and needs to be taken with water, preferably 30 to 60 minutes before food intake, and also check for drug interactions. There are many factors that needs to be considered as well. So the drug interactions, it can be interact with antacids, nexiums, calcium supplements, and iron supplements, and cholesterol lowering medications, and certain anticonvulsant. And we need to make sure that Rebecca has been reviewed by her MO for any concerns. And for her specific, we need to check for the reduction of the goiter. This is important so we can know that the treatment for levothyroxine is effective, and we should be looking at the reduction of the mass of the goiter by the next visit. So we have to monitor Rebecca's goiter size by charting or recording with every visit and coordinating with the endocrinologist. So that's all for the pathophysiology and the pharmacological intervention for Hashimoto's thyroiditis.